1, 2,
And review 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Picture this. You just walked onto the labor and delivery unit for, like, your very first clinical shift.
Oh, that first day is always wild.
Right. So you step into room 3, and the patient is 39 weeks pregnant, gripping the bed rails. And her eyes are just, wide with panic.
Yeah, absolutely terrifying for her, yeah.
And the fetal monitor next to her, which had been chiming along with this really reassuring rhythmic heartbeat, suddenly drops its pitch. It's sounding this long, sustained, just terrifyingly slow tone.
The dreaded bradycardia alarm.
Exactly. The jagged line on the screen just falls into a deep valley, and it's completely not coming back up. And then your preceptor turns to you, the nursing student, and says, well, what is happening, and what exactly do we do right now?
Yeah. That is the ultimate trial by fire, because in that specific moment, you really don't have the luxury of, pulling out a 1,000-page textbook to look up the pathophysiology of fetal bradycardia.
No, not at all.
You literally have seconds.
Right. And honestly, the sheer volume of information thrown at you in nursing school regarding maternal, newborn, and women's health is just, it's staggering.
It really is. I mean, you're expected to understand 2 patients simultaneously.
One of whom you can't even see.
Exactly. In a situation where, normal physiology can pivot into a catastrophic emergency in less than 3 minutes.
Which is why the traditional approach of, reading a textbook from cover to cover just doesn't work for clinical readiness.
No, it fails every time. To be a safe, competent nurse, you have to filter the noise.
So if you are tuning in right now, consider us your personal clinical mentors and study coaches for the next hour. Because we are taking all those massive obstetric sources, all the care plans, the clinical guidelines, and we are aggressively applying the Pareto principle.
No, it's the 80-20 rule.
Right. We're hunting for that 20% of crucial concepts, the physiological patterns, and those safety-critical red flags that will, frankly, generate 80% of your exam points.
And more importantly, keeps your future patients alive.
Exactly. So what's our mission today?
Well, we are going to prioritize high-yield material, but we aren't going to just give you a dry list of facts to memorize, because rote memorization completely fails under pressure.
Oh, 100%. You just blank.
You do. If you don't understand the why behind an intervention, your mind goes blank when the alarms start sounding. So we're going to break down the mechanics, the fluid dynamics, and the raw biology of labor so that your clinical judgment just becomes instinctive.
I love that. No jargon without explanation, no academic fluff, just a deep dive into how to think like an elite OB nurse.
Ready to jump in?
Let's do it. Let's back out of that terrifying room for a second. Because before we can rush in and save the day during an emergency, we have to know what a normal day is supposed to look like.
You have to know baseline to spot the abnormal.
Right. I always think of this like flying a commercial jet.
Yeah.
You wouldn't just throw a student pilot into a nosedive simulation on day 1.
Yeah.
First, you teach them how to read the dashboard while the plane is safely cruising.
That's a really perfect analogy, because in obstetrics, when a patient rolls into triage, your dashboard consists of mapping out 3 interacting forces. They're traditionally called the 3 Ps, which are power, passenger, and passage.
The 3 Ps.
Right. If you don't evaluate how these 3 are interacting, you are flying blind.
Okay, let's break down that dashboard for everyone listening.
Yeah.
Power sounds obvious, right?
Yeah.
Like, that's the uterine contractions, the engine pushing the plane.
Precisely. It's the primary force of labor. But it's not just about, having contractions. It's about their quality.
What do you mean by quality?
Well, we have to assess whether they are strong enough, frequent enough, and of sufficient duration to actually do the mechanical work.
The work of opening the cervix?
Exactly. Opening the cervix and physically moving the baby down.
Yeah.
Then you have the passenger, which is obviously the fetus.
Right.
And for the passenger, we care deeply about the baby's size, their presentation, meaning what part of the body is coming first, and their attitude.
Attitude. Like if they're grumpy about being born.
No, though they usually are. Attitude refers to how their head and limbs are flexed or extended.
Oh, got it. Like, are they tucked into a tight little cannonball, or are they stretching out?
Exactly that. A tightly flexed head, chin to chest, presents the absolute smallest possible diameter to the maternal pelvis.
Which is what we want.
Right. But if the baby extends its neck, like looking up at the ceiling, suddenly the widest part of the head is trying to squeeze through that narrow space, which can literally stall labor entirely.
Ouch. Okay, and that brings us to the third P.
Yes, the passage, which is the maternal bony pelvis and all the soft tissues of the birth canal.
So we have the engine pushing, the passenger navigating, and the tunnel they have to get through.
That's the setup.
But to figure out if this is actually working, we have to measure the cervix. And I have to say, this is where I remember getting completely tangled up in nursing school.
But terminology can be a lot.
It is. Effacement, dilation, station, they just kind of blur together. Let's untangle them for the listeners.
Okay, think of the cervix before labor as a thick, firm cylinder, kind of like a really rigid turtleneck sweater neck about 2 to 3 centimeters long.
Okay, a rigid turtleneck.
Yeah, and it is tightly closed to keep the baby safely inside. But when labor begins, the power, those contractions we talked about, starts pulling that cylinder upward, stretching it over the baby's head.
So it's pulling the turtleneck up and over.
Exactly. So effacement is just the measurement of how much that cylinder has shortened and thinned out.
So it goes from being a thick tube to something like a really thin sheet of paper.
Mm-hmm.
And we measure that in percentages, right?
Correct. 0% effaced means it is still a thick, completely unchanged tube.
And 100%.
100% effaced means it is completely thinned out. You practically can't even feel it distinguishing from the rest of the lower uterus.
Okay, so if effacement is thinning, then dilation is the actual opening of the door.
Yes. Dilation is measured in centimeters from 0, which is locked closed, to 10 centimeters, which is fully open.
10 centimeters is the magic number.
Right, because 10 centimeters is generally considered large enough for a full-term fetal head to pass through.
Now, here is the metric that always feels like a trap on exams. Like, I always got this wrong. Fetal station.
Oh, the numbering system.
Yes. When I first learned this, the numbering system felt completely counterintuitive. Because normally negative numbers mean you're below something, and positive numbers mean you're above it.
But in obstetrics, it's flipped.
Right. Negative numbers mean the baby is high up, and positive numbers mean the baby is low down. Why? How does this map out physically?
I totally see why that gets people. You really have to understand what the 0 line is.
Okay, where is 0?
In the middle of the maternal pelvis, there are these 2 bony prominences called the ischial spines. If you look at a pelvic skeleton, these spines jut inward.
Like little spikes.
Yeah. They represent the absolute narrowest anatomical bottleneck that the baby has to navigate. Because it's the ultimate choke point, obstetricians and nurses use the ischial spines as the 0 landmark.
Okay. So 0 is the equator, the choke point.
Exactly. If the widest part of the baby's head, the biparietal diameter, has reached the level of those ischial spines, we say the baby is at 0 station.
Which means what clinically?
The baby has officially entered the true pelvis. Clinically, we call this being engaged.
Engaged, like they are locked in.
Right. It's a very reassuring sign because it proves the baby's head actually fits into the pelvic inlet.
That makes so much more sense.
Mm-hmm.
So if 0 is the choke point, any number above that choke point is negative?
Right. If the presenting part is above the ischial spines, we measure the distance in centimeters as negative numbers. So -1, -2, -3.
So -5 is.
If a baby is at -5 station, it's essentially floating high up in the false pelvis, completely unengaged.
Which means positive numbers are a positive sign of progress.
Yes. That's a fantastic memory anchor for exams.
Because students see a positive number and freak out.
Exactly. Students see a patient is at verse +3 station, and they panic, thinking a high positive number means a high level of danger. But +1, +2, +3 just means the baby has passed the hardest part and is moving down the birth canal toward the exit.
And +4 or 5.
+4, +5 means the head is crowning at the perineum. So positive numbers mean positive progress toward birth.
I love that. Positive numbers equal positive progress. Okay, so we check the dashboard. The patient is 100% effaced. She's 5 centimeters dilated and at 0 station. What do we actually do with this data? Why do nursing instructors obsess over mapping these exact numbers?
Because labor is a continuum, right? But clinically, we slice it into 4 distinct functional stages. And your nursing interventions completely change depending on which stage the patient is currently in.
So if you get the stage wrong.
If you don't know where she is on the map, you will choose the wrong intervention. which is an immediate safety failure on an exam and obviously in real life.
Let's map out the journey then, from the first contraction to the recovery room. Walk me through the stages.
All right, stage 1 is all about getting the door open. It starts with the onset of true regular contractions, and it doesn't end until the cervix is completely dilated to 10 centimeters.
So it's the longest part.
By far, it is the longest stage, and it's further divided into phases. The early or latent phase is really slow. The cervix might only dilate to 4 or 5 centimeters over many, many hours.
And then?
Then there is the active phase, where the contractions become intense and the cervix dilates much more rapidly.
No, wait. I want to pause on that word rapidly, because I remember reading about something called the Friedman curve, where doctors used to expect women to dilate like absolute clockwork.
Oh, yes. 1 centimeter per hour.
Right. And if you didn't hit that mark, they called it failure to progress and just wheeled you to the OR for a C-section.
Yeah.
Is that still the gold standard?
That is a phenomenal piece of historical context, and honestly, it's a major shift in modern obstetrics that you will be tested on.
Oh, really?
Yes. Back in the 1950s, Dr. Emanuel Friedman plotted thousands of labors on graph paper and created this sigmoid curve that became the absolute law of labor and delivery.
The law of the land.
But here's the catch. Dr. Friedman's patients were largely laboring without epidurals, and the demographics of maternal weight and age back then were very, very different.
Oh, wow. So the data is basically outdated.
Completely outdated. Massive modern studies have shown that normal labor can be significantly slower than the old Friedman curve allowed, especially during that transition from the latent to the active phase.
I imagine epidural changes things too.
Huge factor. An epidural can relax the pelvic floor beautifully, but it can also temporarily slow contractions. Today, we know that as long as the fetal monitor looks good and the mother is safe, we can give her more time.
So we don't just rush to surgery.
Exactly. We don't rush to a cesarean just because she stayed at 6 centimeters for 3 hours.
That is such a vital clinical insight. We are treating the patient, not a 70-year-old graph.
Exactly.
Okay, so stage 1 is getting to 10 centimeters. What is stage 2?
Stage 2 is the pushing stage. It begins the exact second the cervix hits 10 centimeters and ends with the actual physical birth of the infant.
Wait, I want to clarify a huge trap I fell for in simulation lab.
Oh, let's hear it.
Okay, so if a patient is at 8 centimeters, but she tells me, I feel incredible pressure I have to push right now, isn't her body telling her what to do? Like, why shouldn't she push?
Oh, this is one of the most highly tested safety priorities on the NCLEX.
Really? Why?
If she pushes before the cervix is completely out of the way, she is forcing the baby's hard skull directly into the remaining cervical tissue.
Like trying to force a golf ball through the neck of a tight sweater.
Exactly like that. And what happens when you traumatize highly vascular tissue?
It swells up.
It swells massively. The cervix will become acutely edematous. It gets thick, swollen, and super rigid. And once it swells, it might stop dilating entirely.
Oh, wow. So she could get stuck at 8 centimeters permanently.
Yes. You can literally stall the entire labor, turning a smooth vaginal birth into an emergency cesarean just because she pushed too early.
That's terrifying. So what do I do as the nurse?
As a nurse, you have to coach her through the contractions. You have her pant or blow out her breath like blowing out a candle to actively discourage pushing until you confirm she is fully at 10 centimeters.
That is the why. That makes the fact stick. You blow out the candle to save the cervix. Okay, stage 3 is delivering the placenta. And most people think the story ends there. But there is a stage 4.
Yes. Stage 4 is the immediate postpartum period, roughly the first 2 to 4 hours after the placenta delivers.
When everyone is passing the baby around and taking pictures.
Right. The adrenaline of birth wears off, the room empties out, but physiologically, this is where maternal biology undergoes a massive, violent shift. It is the highest risk time frame for maternal mortality due to postpartum hemorrhage.
Because the placenta just detached from the wall of the uterus, leaving a massive open wound, essentially.
A wound the exact size of a dinner plate, with massive blood vessels completely sheared open.
Which sounds fatal. So how does she not just bleed to death?
The uterus is an incredibly powerful muscle. In a healthy stage 4, the uterus dramatically clamps down, contracting tightly to physically pinch those bleeding vessels closed.
It's a biological tourniquet.
That is the perfect way to describe it.
And as the nurse, how do I know if that biological tourniquet is actually working? What's the assessment?
You systematically palpate the maternal abdomen. You press your hand into her lower belly to feel the fundus, which is the top of the uterus.
What should it feel like?
It should feel firm, like a hard grapefruit located right around the level of her belly button.
And if it doesn't?
If you press down and it feels soft, squishy, like a water balloon, we call that a boggy uterus.
Yeah.
You are in a life-threatening crisis called uterine atony.
Uterine atony. The muscle is exhausted and it's just relaxed, letting the blood flow freely.
Yes.
What is the immediate priority? Do I run and get the doctor?
You do not leave the room to call the doctor.
Okay, good to know.
You drop your hands to her abdomen and you perform vigorous fundal massage. Very vigorous. You physically squeeze and knead that uterus through her abdomen to irritate the muscle fibers into contracting. It is painful for the patient, but it is 100% life-saving.
And what else? I can't just massage forever.
At the same time, you are yelling for help and preparing to administer uterotonic medications, things like pitocin, methergine, or hemabate, to chemically force the muscle to clamp down.
Oh, let's touch on those meds really quickly because pharmacology is huge on exams. Pitocin we know, but what about methergine and hemabate? Any traps there?
Huge traps. Methergine raises blood pressure. So if your patient has preeclampsia or high blood pressure, methergine is strictly contraindicated. You will cause a stroke.
Wow, okay. High BP means no methergine and hemabate.
Hemabate causes severe bronchospasm. So if your patient has a history of asthma, hemabate is contraindicated.
See, this is why I love digging into the mechanisms. Massage to the fundus sounds like a gentle spa treatment. Vigorously compress the bleeding organ and cross-check asthma meds to stop a hemorrhage is the reality.
Exactly.
Okay, before we move on from the dashboard, we talked about checking the cervix to get all these measurements. But is there ever a time when you absolutely should not perform a vaginal exam?
Yes. And this is a guaranteed exam question.
So, listeners, pen and paper out.
If a patient arrives in triage complaining of bright red, undiagnosed vaginal bleeding, a digital vaginal exam is strictly contraindicated.
Why? If she's bleeding, shouldn't I find out where the blood is coming from?
Because you might be the cause of her bleeding to death.
Wait, really?
Yes. She could have a condition called placenta previa, where the placenta has implanted abnormally low in the uterus, completely covering the cervical opening.
Oh, wow.
If you blindly insert your fingers into the cervix, you could literally punch right through the highly vascular placenta. You will cause a catastrophic hemorrhage that will exsanguinate the baby and the mother in minutes.
That is terrifying.
So you must wait for a transvaginal ultrasound to locate the placenta before anyone touches her cervix.
Okay, that is a massive safety priority. Never check a bleeding cervix blindly. So we've covered the mother's dashboard. We understand the physical machinery of labor, but there is a second patient in the room.
The one we can't see.
Exactly. Let's pivot to how we know if the baby is surviving this journey. This brings us to electronic fetal heart rate monitoring. I feel like this is the holy grail of obstetrics exams.
It absolutely is because, as we said earlier, the fetal monitor is the baby's only voice. During labor, the baby is subjected to tremendous mechanical and hypoxic stress.
Hypoxic stress.
Yeah, every time the uterus contracts, it temporarily squeezes the blood vessels in the placenta, briefly cutting off the baby's oxygen supply.
It's like doing a strenuous workout where someone just pinches your nose every 3 minutes.
Precisely. A healthy, well-oxygenated fetus with good reserves can tolerate that intermittent stress perfectly fine. A fetus that is compromised cannot. The monitor translates their neurological and cardiovascular response to that stress right onto a strip of paper.
So we need to learn how to read the language of the monitor. The guidelines group tracings into a 3-tier system, right? Category 1, 2, and 3. Let's start with Category 1. This is the perfect A+ baby.
Category 1 is normal. It tells you the fetal acid-base status is perfectly balanced.
What are the rules to be Category 1?
To earn a Category 1 rating, the tracing must meet strict criteria. First, the baseline heart rate must be between 110 and 160 beats per minute.
110 to 160. Got it.
Second, and most importantly, the baseline variability must be moderate.
I want to spend some time on variability because I remember staring at these strips and just seeing jagged lines. What does variability actually mean biologically?
It is the most beautiful thing you can see on a monitor. Variability refers to the tiny beat-to-beat fluctuations in the heart rate.
Like it shouldn't be smooth.
Right. If you look at the tracing, it shouldn't look like a straight line drawn with a ruler. It should look erratic, jagged, squiggly.
But why is erratic good? Usually in adult cardiology, erratic means you have an arrhythmia and you're about to code.
True, but in a fetus, it proves that the central nervous system is intact, oxygenated, and functioning.
How so?
The fetal heart is in a constant tug of war between the sympathetic nervous system, which acts like the gas pedal trying to speed the heart up,
Okay, sympathetic is the gas.
and the parasympathetic nervous system via the vagus nerve, which acts like the brakes trying to slow it down.
Gas brake.
Exactly. When a healthy, oxygenated fetal brain is managing that tug of war, the heart rate constantly micro-adjusts, creating that squiggly line. We call it moderate variability when those fluctuations are between 6 and 25 beats per minute in amplitude.
So if you see modern variability,
You can take a deep breath because it virtually guarantees the baby's brain is not hypoxic or acidotic at that exact moment.
okay, so squiggly means the brain is awake and fighting. What is the opposite? What makes a tracing category 3 the ultimate emergency?
Category 3 means severe fetal hypoxia and acidemia. The brain is literally shutting down.
And what does that look like?
The hallmark of a Category 3 strip is absent variability. The line goes completely flat, smooth, like a ruler.
Because the brain doesn't have enough oxygen to manage the gas and the brake pedals anymore.
Right. The nervous system is deeply depressed. But absent variability alone isn't automatically Category 3. I mean, maybe the baby is just in a deep sleep cycle, or the mother had narcotic pain medication.
Oh, that makes sense. Meds cross the placenta.
Exactly. It becomes a Category 3 emergency when that flat line is combined with pathological decelerations. Specifically, recurrent late decelerations, recurrent severe variable decelerations, or persistent profound bradycardia.
Okay, let's unpack these decelerations. These are the heart rate drops that happen during the tracing. There are early, late, and variable decelerations. They sound simple, but I know their underlying physiology is entirely different.
Completely different.
Let's start with early decelerations.
Early decelerations are visually apparent, gradual, symmetrical decreases in the fetal heart rate. They look like gentle, shallow U-shapes.
Okay, shallow U-shapes.
But the defining characteristic is their timing. They perfectly mirror the uterine contraction.
Meaning, as the contraction gets stronger and goes up on the bottom half of the monitor paper, the fetal heart rate goes down on the top half.
Yes. The lowest point of the heart rate drop, the nadir, occurs at the exact same moment as the peak of the contraction.
Okay, I'm putting myself in the student's shoes here. A contraction squeezes the baby, heart rate drops. That sounds bad. Why is this considered an expected, normal finding?
Because of why it's happening. Early decelerations are caused by pure mechanical head compression.
Head compression.
As the uterus contracts, it forcefully swishes the baby's skull against the maternal pelvis. This physical pressure on the skull stimulates the fetal vagus nerve, which reflexively slows the heart rate.
Just a reflex.
Exactly. As the contraction fades and the pressure releases, the heart rate returns to normal.
So it's not a lack of oxygen.
Not at all. It just means the head is descending into the birth canal. It's actually a sign of progress.
So what's the nursing action?
The appropriate nursing action for early decelerations is to simply document the finding and perhaps perform a vaginal exam to see if the patient is fully dilated and ready to push.
Okay, that makes sense. Now let's shift to late decelerations. These are the bad ones. How do they look different, and why are they so dangerous?
Visually, late decelerations are also gradual, shallow U-shapes.
So they look the same as earlies.
Visually, yes, but their timing is shifted to the right. The deceleration does not start until after the contraction has reached its peak.
After the peak.
And the heart rate doesn't return to baseline until well after the contraction has completely ended.
So the contraction peaks, and then a moment later, the heart rate bottoms out.
Right.
Why the delay?
Because this isn't a mechanical reflex. This is uteroplacental insufficiency. It is a true oxygen crisis.
Let's walk through the plumbing of that. What is actually failing?
Well, the placenta is essentially the baby's lung. Maternal blood flows into the placenta, transferring oxygen to the fetal blood. But during the peak of a contraction, the uterine muscle clamps down so tightly that it physically halts the flow of maternal blood into the placenta.
Like stepping on a garden hose.
Exactly. For a few seconds, the baby gets no new oxygen. Now, a healthy placenta has built up oxygen reserves in the intervillous spaces, so the baby basically holds its breath, tolerates the squeeze, and its heart rate doesn't change.
But if the placenta is failing?
If it's failing, perhaps due to maternal hypertension, gestational diabetes, preeclampsia, or simply because the mother is 2 weeks past her due date, those reserves are completely gone.
So when the contraction peaks and steps on the hose, the baby instantly runs out of air.
Right. And as the oxygen level in the fetal blood plummets, Chemoreceptors in the baby's brain detect the hypoxia and trigger the heart rate to slow down in a desperate attempt to conserve myocardial energy. It takes a moment for the oxygen level to drop, the brain to register it, and the heart to slow down. That's why the drop happens late, after the contraction has already peaked.
Holding your breath on a treadmill when you already have bad lungs. That is a terrifying physiological picture.
It is.
So if you see recurrent late decelerations, you know the baby is suffocating. What about variable decelerations? How do they fit in?
Early decels are gradual and mirror the contraction. Late decels are gradual and shifted right. Variable decelerations are abrupt.
Abrupt, like a sharp drop.
They are visually sheer cliffs. The heart rate plummets suddenly, dropping more than 15 beats per minute in less than 30 seconds. They look like sharp V's or W's on the tracing.
Okay, V for variable.
Exactly. And they are variable because they can happen at any time. They don't have a strict relationship to the contractions.
What causes a sheer cliff drop like that?
Umbilical cord compression. The umbilical cord is the baby's lifeline. If it gets squished, maybe the baby rolls over on it, or the fluid is low and it gets pinched between the fetal shoulder and the uterine wall, the blood flow is instantly obstructed.
And how does that instantly crash the heart rate?
It's a baroreceptor response. When the cord is pinched, the fetal blood pressure skyrockets because the blood has nowhere to go.
It was backs up.
Right. Pressure sensors or baroreceptors in the fetal aorta scream at the brain, "Pressure is too high." The vagus nerve fires instantly, slamming the brakes on the heart to lower the blood pressure. When the cord is unpinched, the heart rate shoots right back up.
It is amazing how much of this is just high-stakes biological plumbing and electrical wiring.
That's all it is.
Okay, so as the nurse, you are staring at this monitor.
Yeah.
You see a Category 2 or Category 3 strip say, absent variability with recurrent late decelerations. The baby is hypoxic. What do you actually DO?
You immediately initiate uterine resuscitation. Your singular goal is to maximize oxygen delivery to the placenta and improve umbilical blood flow.
Do we use an acronym for this? I feel like nursing school is 90% acronyms.
Yes, the acronym LION is very helpful here. L for left lateral position, I for IV fluid bolus, O for oxygen, and N for notify provider, and stop pitotin.
Let's break down the why for each one. Why change the mother's position first?
If the mother is lying flat on her back, the entire weight of the gravid uterus crushes her inferior vena cava, drastically reducing blood return to her heart, which drops her blood pressure and starves the placenta.
A vena cava syndrome.
Right. Rolling her to her left or right side takes the weight off the vena cava, restoring blood flow. Furthermore, if you are seeing variable decelerations from a compressed cord, physically shifting the mother's weight can literally cause the baby to float off the cord, instantly fixing the problem.
So position change is always your first move for variables.
Always.
Okay, step 2 is an IV fluid bolus, usually lactated ringers. Why?
Physics. More fluid volume in the maternal intravascular space equals higher maternal blood pressure, which equals stronger perfusion pressure driving blood into the placenta.
Especially if she had an epidural, right?
Exactly, because epidurals cause vasodilation and drop maternal blood pressure anyway.
Step 3, oxygen. Applying a non-rebreather mask at 10 liters.
Yes. You want to hyperoxygenate the maternal blood so that whatever blood is making it through the failing placenta is carrying maximum oxygen capacity to the fetus.
And the final step, which might be the most critical, turning off the pitocin or oxytocin.
If the contractions are the stressor causing the hypoxia, which they absolutely are in the case of late decelerations, you must stop the artificial engine driving the contractions.
Turn off the engine.
Pitocin forces the uterus to contract. You must turn it off immediately to give the placenta time to rest and refill with oxygen.
Okay, let's talk exam traps for fetal monitoring. Where do students usually get tripped up?
The most common trap is misinterpreting the baseline fetal heart rate. The normal range is 110 to 160. Students see a tracing where the baseline is 175. It's fetal tachycardia.
And they think what?
They often choose an answer like, the baby is active and tolerating labor well, thinking a fast heart is a strong heart.
Right, like the baby's just jogging.
Exactly. But fetal tachycardia is a massive red flag. While it can be a side effect of maternal medications like terbutaline, the most dangerous and testable cause of fetal tachycardia is maternal or intraamniotic infection called chorioamnionitis.
Infection.
The fetal heart rate will often spike hours before the mother even spikes a fever. It is an early warning siren for sepsis.
That is a phenomenal clinical pearl. Tachycardia equals suspect infection. So up until now, we've been talking about this intricate dance of labor, assuming the timeline is normal, like a 39 or 40-week term pregnancy.
Right.
But what happens when this entire physiological dashboard is abruptly moved up by, say, 8 weeks?
That changes the entire calculus of risk. A baby born at 40 weeks has fully developed lungs, plenty of brown fat for temperature regulation, and a mature liver. A baby born at 32 weeks has absolutely none of those things.
Which bridges us perfectly into preterm labor, PPROM, and intra-amniotic infection. Let's get the definitions crystal clear, because I know the NCLEX loves to trick people here. What exactly is preterm labor?
Preterm labor is defined as regular uterine contractions that cause actual, measurable cervical change effacement or dilation occurring between 20 weeks and 36 weeks and 6 days of gestation.
The key phrase there is cervical change.
Mm-hmm.
Because a woman can have contractions at 30 weeks that aren't labor, right?
Correct. A pregnant woman can experience Braxton Hicks contractions or contractions caused by dehydration or a urinary tract infection.
So if she's just dehydrated?
If the uterus is contracting but the cervix remains long, thick, and closed, she is not in preterm labor. We might hydrate her, treat the UTI, and send her home. But if those contractions are actually thinning and opening the cervix, she is in true preterm labor, and we have to intervene aggressively.
What about PPTROM? How does that fit in?
PPROM stands for preterm pre-labor rupture of membranes. This is when the amniotic sac, the bag of waters, spontaneously breaks before 37 weeks and before any contractions have even started.
Why is that such a massive emergency? If the water breaks, doesn't that just mean the baby is coming?
It's an emergency because of what the amniotic sac actually does. It is a thick, highly resilient, completely sterile barrier. It is a fortress that protects the fetus from the billions of bacteria residing in the vaginal canal.
Oh, wow.
When that sac ruptures prematurely, you have essentially lowered the drawbridge to the fortress. Bacteria can freely ascend from the vagina directly into the uterine cavity.
Which leads to chorioamnionitis.
Exactly. Chorioamnionitis is a severe ascending bacterial infection of the amniotic fluid, the membranes, and the placenta. It creates a highly toxic, inflammatory intrauterine environment.
And that causes labor.
It will trigger aggressive preterm labor, and if left untreated, it leads to maternal sepsis, and fetal brain damage.
So how do you know if the fortress has been breached and an infection has taken hold? What are the signs?
You look for the clinical hallmarks. We already mentioned the earliest sign, fetal tachycardia.
Right.
Then you monitor the mother's temperature. A fever greater than 38 degrees Celsius or 100.4 degrees Fahrenheit is highly concerning. You also assess the mother's uterus. Is it exquisitely tender to the touch between contractions?
Okay, tender uterus.
And finally, you assess the amniotic fluid itself.
What should it look like normally?
Normal amniotic fluid is clear, pale, and relatively odorless. If the fluid leaking from the vagina is cloudy, yellow, purulent, or has a foul, offensive odor, you are dealing with a severe intraamniotic infection.
Okay, let's walk through scenario. A patient arrives in triage at 31 weeks. She's having regular contractions, and her cervix has dilated from 1 centimeter to 3 centimeters in the last 2 hours. She is in active preterm labor. The water is intact.
Okay, classic preterm labor.
What is our primary goal? Do we try to stop the labor completely and send her home to stay pregnant for another 9 weeks?
Generally, no. Once the biochemical cascade of true preterm labor has firmly established itself, it is incredibly difficult to halt it completely. Our primary realistic goal is to buy time. Specifically, we want to buy 48 hours.
Why 48 hours? What are we doing in that window?
We need that 48-hour window to administer intramuscular corticosteroids to the mother, usually a drug called betamethasone.
Why steroids? I normally associate steroids with reducing inflammation, like for asthma or an allergic reaction.
In a premature fetus, the biggest threat to life is respiratory distress syndrome. A 31-week fetal lung has not produced enough surfactant.
Surfactant is the soapy stuff, right?
Yes, the soapy substance that coats the inside of the alveoli and keeps them from collapsing flat every time the baby exhales. Without it, the lungs just stick together. When you inject betamethasone into the mother, it crosses the placenta and aggressively stimulates the fetal lungs to synthesize and release surfactant.
Oh, wow. So you are chemically accelerating fetal lung maturity while they are still in the womb.
Exactly. But it takes about 24 to 48 hours for the drug to reach maximum efficacy. So we have to pause the contractions just long enough for the steroids to work.
And how do we hit the pause button on labor?
We use medications called tocolytics. Toco, meaning labor. Easylytic, meaning to break or stop. These are smooth muscle relaxants. The sources list 3 primary high-yield drugs: terbutaline, nifedipine, and magnesium sulfate.
Let's talk pharmacology, because nurses administer these. Terbutaline, how does it work and what are the side effects?
Terbutaline is a beta-2 adrenergic agonist. It binds to receptors in the uterine muscle and causes them to relax. However, it also binds to beta receptors in the heart and lungs.
Which means?
It is notorious for causing severe maternal tachycardia, palpitations, and tremors. The mother will often tell you she feels like her heart is beating right out of her chest.
So what's a nursing implication?
You must assess her heart rate before giving every single dose. If her pulse is already over 120, you hold the drug and notify the provider.
Okay. Nifedipine. I recognize that as a blood pressure pill.
Yes, it's a calcium channel blocker. The uterine muscle requires an influx of calcium into its cells to perform the actin-myosin cross-bridging that causes a contraction. Nifedipine physically blocks the calcium channels. No calcium, no contraction.
Brilliant. But it's a blood pressure med.
Right, because it relaxes smooth muscle everywhere, it also dilates maternal blood vessels. The major side effects are maternal hypertension, dizziness, and flushing. You have to monitor her blood pressure closely to ensure she doesn't bottom out and drop perfusion to the placenta.
That makes perfect mechanical sense. Now let's talk about the heavy hitter, magnesium sulfate. I remember this being the most terrifying drug to manage on the L&D floor.
Oh, it is a high alert medication because the therapeutic window is very narrow and magnesium toxicity can be fatal.
So what does it do?
Magnesium sulfate is a central nervous system depressant and a potent, smooth muscle relaxant. It can be used as a tocolytic to relax the uterus. But there is a second, highly testable reason we give it in preterm labor, completely separate from stopping contractions. Fetal neuroprotection. Massive studies showed that if you infuse magnesium sulfate into a mother delivering before 32 weeks, it stabilizes the fragile cerebral blood vessels in the extremely premature fetal brain.
Wait, really?
Yes. It drastically reduces the incidence and severity of devastating intraventricular hemorrhages and cerebral palsy in the neonate.
So even if the labor is unstoppable and the baby's coming today, you still hang the mag to protect the baby's brain.
Exactly. And your nursing priority while the mother is on a mag drip is assessing for toxicity.
Right, because you said it's a CNS depressant.
Because it depresses the nervous system, you must do hourly checks of her deep tendon reflexes, like the patellar knee jerk. If her reflexes disappear, her nervous system is too depressed.
No, reflexes are bad.
Very bad. You also check her respiratory rate. If it drops below 12 breaths per minute, the magnesium is paralyzing her diaphragm.
Oh my God.
If either of those happen, you immediately stop the infusion and prepare to administer the antidote, which is calcium gluconate.
That is an absolute goldmine of exam prep right there. Lose the reflexes, stop the drug, grab the calcium gluconate. Okay, what if the scenario is different? The patient is 32 weeks and her water breaks. PP problem. She isn't having contractions yet, but the fortress is breached. What is our priority action?
Infection prevention is your absolute paramount priority. You do not touch her cervix. You strictly limit or completely avoid digital vaginal exams.
Because of the bacteria.
Right. Every time a provider introduces a gloved hand into the vaginal canal, they are physically pushing ascending bacteria closer to the sterile uterine cavity. You manage her expectantly.
What does expectant management look like?
Monitoring her temperature, monitoring the fetal heart rate for tachycardia, assessing the fluid for foul odor, and administering prophylactic antibiotics to delay chorioamnionitis.
Okay, we've covered the nuances of premature labor. Let's bring our timeline back to a full-term pregnancy.
Back to 40 weeks.
Yes. The patient is 40 weeks. She's fully dilated. The monitor looks okay. The baby's is coming down the birth canal. And then suddenly, everything stops. We are entering the territory of dystocia and obstetrical emergencies.
This is where we move from physiological management to mechanical trauma-level crisis management. Dystocia literally translates to difficult, abnormal, or dysfunctional labor.
Let's set the scene for the most terrifying dystocia of all. The patient is pushing, the baby's head crowns and delivers, the head is completely out in the world, but then, horrifyingly, the head pulls back tightly against the mother's perineum. What is happening?
You are describing the turtle sign. It looks exactly like a turtle pulling its head back into its shell, and it is the diagnostic hallmark of a shoulder dystocia.
Why does the head pull back? What is stunning?
The mechanics are brutal. The fetal head successfully navigated the pelvis, but the baby's anterior shoulder, the shoulder facing the ceiling, has become physically wedged and locked behind the mother's pubic symphysis, the thick bone at the front of the pelvis.
So it's bone on bone.
Exactly. The uterus is contracting, trying to push the body out, but the bone is acting like a brick wall blocking the shoulder. The head pulls back because the neck is being stretched tight, but the body can't follow.
This sounds horrific. Why is this a drop-everything life-or-death emergency?
Because of the umbilical cord, once the baby's head is out, the umbilical cord is dragged down into the birth canal, and it is now being severely compressed between the baby's stuck body and the mother's pelvis.
So the cord is crushed,
Uh,
and the baby can't breathe.
right. The baby's head is in the air, but its chest is compressed inside the tight birth canal, so it cannot expand its lungs to breathe. And its oxygen supply from the cord is totally crushed. You have roughly 5 minutes to dislodge that shoulder and deliver the baby before profound, irreversible hypoxic brain damage occurs.
5 minutes. Okay, you see the turtle sign, you hit the emergency call light, the room floods with the rapid response team. What are the immediate hands-on nursing interventions?
The standard first-line intervention is the McRoberts maneuver, performed simultaneously with suprapubic pressure.
Walk me through the biomechanics of McRoberts. What am I doing to the mother's body?
You and another nurse grab the mother's legs, remove them from the stirrups, and sharply, forcefully hyperflex her thighs tightly back against her own abdomen. Think knees to nipples.
How does that unstick a shoulder?
It alters the geometry of the pelvis. Hyperflexing the legs straightens the maternal sacrum and physically rotates the pubic symphysis upward, opening the angle of the pelvic inlet.
Oh, it pivots the bone.
Yes, it often creates just enough clearance for that stuck shoulder to pop free and slide under the bone.
But if McRoberts alone doesn't work, we add suprapubic pressure. And I know there's a deadly exam trap here regarding where you push.
This is one of the most critical safety distinctions you will ever learn. To apply suprapubic pressure, you stand on a stool, make a fist, and push downward and inward directly over the mother's pubic bone, low down on her pelvis.
Over the pubic bone.
Your goal is to physically find the baby's stuck shoulder through the skin and push it downward, collapsing it so it can clear the bone.
What happens if a student panics and pushes on the top of the mother's stomach instead, like up by her ribs?
That is called fundal pressure, and it is absolutely strictly contraindicated during a shoulder dystocia.
Why? What does it do?
If you push on the fundus, the top of the uterus, you are applying massive downward force onto a baby whose shoulder is firmly wedged against a solid bone. You will impact the shoulder even tighter.
Oh, that makes sense. You're just jamming it in.
You will cause severe brachial plexus nerve injuries, snapping the clavicle, and you run a massive risk of physically rupturing the mother's uterus from the pressure. Suprapubic pressure only, never fundal.
That is a vivid image to remember. Never push from the top when they are stuck at the bottom.
Yeah.
What about other mechanical dystocias like presentation issues? Not every baby comes head first.
Right. A normal presentation is vertex with the chin tucked, but many babies are breech, meaning the buttocks or the feet are presenting first.
What are the different flavors of breech?
There are 3 main types. Frank breech is the most common. The baby's hips are flexed, but their legs are extended straight up by their ears, like a diver touching their toes.
Okay, Frank is folded in half.
Then there's complete breech, which means the baby is sitting cross-legged Taylor style right over the cervix. And footling breech is when one or both feet are pointing straight down and actually drop into the vagina.
Why are we so afraid of delivering breech babies vaginally?
The biggest danger, especially with a footling breech, is cord prolapse, which we will cover in a moment. But there is also the massive risk of head entrapment.
Head entrapment.
The body and legs are smaller than the head. In a breech delivery, the body might deliver easily through a cervix that is only 8 centimeters dilated. But then the large, hard skull gets to the cervix and gets completely stuck.
Oh my God. The body's out, but the head is trapped.
The body is out, but the head is trapped inside, compressing the cord. It is catastrophic. Most breech presentations today are delivered via scheduled cesarean.
Is there any way to fix a breech presentation before labor starts? Like, can we flip them?
Providers can attempt an external cephalic version, or ECV. Around 37 weeks, under ultrasound guidance, the provider places their hands firmly on the mother's abdomen and physically attempts to roll the baby into a head-down position.
That sounds like it involves a lot of force.
It does, and it carries risks. It can cause the placenta to abrupt or can entangle the umbilical cord, causing immediate fetal distress requiring a crash C-section.
Is there an exam trap for ECVs?
Yes, regarding blood typing. The forceful manipulation can cause microtraumas in the placenta, leading to a mixing of maternal and fetal blood.
Oh, the RH factor.
Exactly. If the mother has an Rh negative blood type, this mixing can cause her to form antibodies against the baby's blood. As a nurse, you must ensure that an Rh negative mother receives a dose of Rh immune globulin, or RhoGEM, whenever an ECV is attempted.
Okay, we've covered the stuck shoulders and the backwards babies. Let's move to the final module, the drop everything emergencies. These are the vascular and anatomical disasters where minutes equal brain cells or life and death. Let's start with the one you just mentioned, prolapsed umbilical cord.
We've talked about the umbilical cord being compressed inside the uterus during variable decelerations. A cord prolapse is when the umbilical cord physically falls out of the cervix and into the vagina ahead of the presenting part of the fetus.
How does that even happen?
It almost always happens at the exact moment the amniotic sac ruptures when the water breaks. If the baby's head is not firmly engaged down in the pelvis, if they are at a high negative station, like -3, there is a gap between the head and the cervix.
And the fluid just washes it out.
When the water breaks, the sudden gush of fluid washes the slippery umbilical cord down through that gap and out the cervix.
And then the heavy bony head descends behind it.
Yes. The heavy head comes down and pinches the cord tightly against the bony walls of the maternal pelvis. Blood flow is completely and instantly occluded.
The baby is literally sitting on his own air hose. How do you know this has happened?
The fetal monitor will instantly show profound, sustained fetal bradycardia or massive, unrecovering variable decelerations. The heart rate will crash to 60 beats per minute and stay there.
That's horrifying.
Or you might be performing a vaginal exam right after the water breaks, and instead of feeling a hard, smooth skull, your fingers feel a soft, pulsating, rope-like cord.
Okay, this is where I need to ask a very skeptical question. Because my instinct, if an organ is falling out of the body, is to put it back in. Do I gently push the cord back up into the uterus where it belongs?
Never. That is a massive exam trap and a fatal clinical error.
Really? Never?
You never, ever manipulate, massage, or attempt to stuff a prolapsed cord back inside. Handling the umbilical cord causes severe vasospasm. The blood vessels inside the cord will aggressively clamp shut from the irritation, permanently cutting off whatever tiny amount of oxygen was still flowing.
Okay, so I don't touch the cord. What do I do?
Your hand is already in the vagina from the exam. You keep it there. You take your sterile gloved fingers, you find the baby's hard skull, and you push it firmly UP toward the ceiling.
Wait, you want me to push the baby back in?
You are manually lifting the heavy fetal head off the umbilical cord, creating space for blood to flow.
So I literally hold the baby's head up inside the mother.
Yes. And you do not remove your hand. You stay in that extremely awkward, physically exhausting position while you yell for help, while the team rushes in, while they move the mother to a stretcher, and you literally ride on the bed with your hand inside the patient all the way to the operating room.
Oh, man.
You stay there until the surgeon makes the abdominal incision and pulls the baby out from above. You are the physical bridge keeping that baby alive.
That is absolutely wild, and it highlights how critical the nursing role is. What else are we doing to help gravity?
You want gravity to pull the baby away from the pelvis. You immediately reposition the mother into an extreme knee chest position.
Knee chest.
Where she is on her hands and knees with her chest resting on the mattress. Or you put her into steep Trendelenburg, where the head of the bed is tilted drastically down and her hips are elevated.
Okay, that is cord prolapse, head UP, hips UP. What is the next major emergency?
Uterine rupture. This is the catastrophic tearing apart of the muscular layers of the uterus. The structural integrity of the organ fails.
The uterus just rips open.
Yes. The amniotic fluid, the placenta, and sometimes the entire fetus itself can be expelled out of the torn uterus directly into the maternal abdominal cavity.
That sounds like something out of a horror movie.
Yeah.
Who is at risk for their uterus just tearing open?
In the United States, the single greatest risk factor is a scarred uterus from a previous cesarean section.
Ah, the scar tissue.
Right. When a woman opts for a TOLAC, a trial of labor, after cesarean, attempting a vaginal birth, she is monitored continuously, specifically for this risk. The old surgical scar on the uterus is the weakest point.
So if contractions get too strong?
If the uterus is hyperstimulated, perhaps by aggressive doses of pitocin driving contractions too hard and too fast, that scar tissue can just give way under the immense pressure.
How do you spot a rupture before it's too late? What are the clinical signs?
It is sudden and violent. The classic presentation is the patient screaming in acute, severe, tearing abdominal pain that is distinctly different from her contraction pain.
In the monitor?
On the monitor, you will see a sudden loss of uterine tone. The rhythmic contraction mountains just disappear into a flat line because the torn muscle can no longer contract. The fetal heart rate will crash into profound bradycardia as the placenta shears off.
And what happens to the physical exam?
Yeah.
Where's the baby?
This is a highly testable finding. A sudden loss of fetal station.
Loss of station.
If you checked her 10 minutes ago and the baby was at +2 station, deep in the pelvis, and now she is in agonizing pain, and you check again and you can't feel the head at all, the baby has slipped back up and out of the torn uterus into the abdomen.
Sudden pain, flat contractions, baby disappears. What is the intervention?
Immediate crash laparotomy and cesarean. Your role is prepping for massive maternal hemorrhagic shock. You need 2 large-bore IVs, 18 gauge or larger, pumping in rapid fluid resuscitation and preparing for massive blood transfusions. The mother is bleeding out internally and the baby is suffocating.
Which brings us to the final emergency, which also involves massive bleeding. Placental abruption or abruptio placentae.
Yes. The placenta is supposed to remain firmly attached to the uterine wall until stage 3 of labor, after the baby is born. An abruption is the premature separation of the placenta from the uterine wall while the baby is still inside.
It just tears away.
It can be a partial separation at the edges or a complete, devastating separation.
When the placenta tears away, what is the immediate consequence?
2 things happen simultaneously. First, the area of the placenta that detached is no longer exchanging oxygen, so the fetus instantly experiences hypoxia, leading to late decelerations or bradycardia.
And the second?
Second, the maternal spiral arteries that were feeding that placenta are now sheared open and bleeding massively.
But I've heard that sometimes with an abruption, you don't even see any blood. How is that possible?
That is a crucial distinction. It depends on where the placenta separates. If it separates at the edges, the blood flows down past the membranes and out the cervix, presenting as visible, dark red vaginal bleeding.
But if it's not at the edges?
If it separates directly in the center, the edges remain sealed to the uterine wall. The blood pumps out and pools behind the placenta, creating a massive retroplacental hematoma.
Oh, a concealed hemorrhage.
Exactly. The mother could lose a liter of blood into her uterus and you wouldn't see a drop on the bed sheets.
That is terrifying. If I can't see the blood, how do I know it's happening?
Pain and rigidity. As the blood fills the enclosed space of the uterine muscle, it irritates the myometrium, causing continuous, severe, knife-like abdominal pain.
So it hurts continuously, not just during a contraction.
Right. And the uterus becomes hypertonic. It refuses to relax. If you palpate the mother's abdomen, it will feel rock hard, rigid, and board-like.
A rigid, board-like abdomen. That is a massive red flag.
It is the classic clinical sign of a severe abruption. The treatment is the same as a rupture. Rapid maternal hemodynamic support, oxygen, and an immediate emergency cesarean to save the baby and stop the bleeding.
Okay, we have covered an incredible, intense amount of ground today. From the calm baseline of a normal dashboard down the steep cliffs of decelerations and into the absolute chaos of prolapsed cords and ruptures. What strikes me is how interconnected all of this is.
It's all connected.
You can't understand a late deceleration if you don't understand placental perfusion. You can't understand a shoulder dystocia if you don't understand the anatomy of the maternal pelvis.
And that is exactly what the NCLEX and your clinical instructors are testing. They are not testing your ability to just regurgitate a definition. They are testing your clinical judgment.
Right.
Can you look at a rigid abdomen and a crashing fetal heart rate, recognize the pattern of an abruption, understand the underlying physiology of hemorrhagic shock, and prioritize your actions to start an IV and prep the OR? That is what makes you a safe nurse.
Before we sign off, I want to pivot slightly. We spent this entire hour hyper-focused on the physical interventions, the fluid boluses, the oxygen masks, the McRoberts maneuver, the raw mechanics of saving a life. But there's another layer to this that often gets lost in the adrenaline.
The psychological impact.
Yes. I want you, the listener, to pause and consider the psychological trauma of a stat crash C-section or a severe postpartum hemorrhage. Think about the patient's perspective. She came in with a birth plan. Maybe she had soft music playing and dim lighting. She was expecting a beautiful natural transition to motherhood.
And in the span of 60 seconds, her reality shatters. An alarm sounds. A dozen strangers in scrubs sprint into her room. The lights are thrown on. Someone yells, "Cord prolapse."
It's pure chaos.
You leap onto her bed and insert your hand into her body. She's thrown onto a gurney, sprinted down a hallway, strapped to an operating table, and put to sleep under general anesthesia before she can even ask if her baby is going to die.
It is an acute, profound psychological crisis.
Yeah.
And surviving the physical emergency is only step one. The challenge I want to leave you with to mull over as you prepare for your career is this. As a future nurse, you are the face of that trauma.
You really are.
How will your communication, your eye contact, your tone of voice, and your calm, authoritative presence in those frantic, terrifying 10 minutes alter that patient's mental health recovery for the next 10 years?
It's a powerful question. A technician can start a large brevet. A truly excellent nurse manages the physical pathophysiology while fiercely protecting the patient's dignity, validating her fear, and providing a sense of psychological safety, even in the midst of absolute chaos.
Even if it's just looking her in the eye as they wheel her down the hall and saying, I am right here with you and we're going to take care of your baby. That is the art of nursing layered right over the science.
Well said.
To all the nursing students out there, take a deep breath. Review these physiological patterns. Trust your training. Remember that behind every alarm is a physical mechanism you can understand, and behind every patient is a human being looking to you for safety. Go confidently tackle those exams and your clinicals. You've got this. We'll see you on the next deep dive.